I'm Tyral. I'm one of the infectious diseases fellows at Charlotte, and I'm going to be presenting cavitary lung disease today. In terms of the outline of the talk, sorry, I'm just going a bit slow. Okay, so in terms of the outline of the talk, we'll first have a definition of cavitary lung disease. We'll look at some cavity mimics we find CT, and then we'll look at the etiology of cavitatory, the spectrum of cavitatory disease, and then we'll go through briefly acute infections, chronic infections, and then lastly, just an algorithmic to management with this presentation, just in the essence of time. So in terms of your definition of lung cavitation, so cavity is defined as a gas-filled space. So it's usually seen as a lucency or a low attenuation area that can occur within a nodule, a mass, or an area of parenchymal consolidation. It has a clearly defined wall of more than 4 millimeters in thickness, and cavities can be defined as acute or subacute, those that are less than 12 weeks old, and chronic cavities, those which are longer than 12 weeks in duration. There are quite a few conditions that can mimic cavities, and these include cysts, emphysema, infected bully, and cystic bronchiectasis. So we're just going to briefly go through the cavity mimics. And the first one we'll talk about is cysts. So pulmonary cysts are actually round, thin-walled, low attenuation spaces or lucencies inside the lung. And cysts usually contain air, but can occasionally contain fluid or solid material. So the term cyst is actually a misnomer because it usually refers to a focus of gas. There are quite a few causes of pulmonary cysts, and it can be congenital or acquired. So this is a CT image, and just in case my cursor isn't working, I've just marked them with yellow arrow so that the yellow arrow is pointing at a lung cyst. In terms of emphysema, so emphysema is a permanent enlargement of the air spaces, usually distal to the terminal bronchioles, and they're accompanied by destruction of the alveolar wall, and they may or may not have accompanying fibrosis. So here again is a CT image of emphysematous change. Okay, then this is an image of infected bully. So to diagnose an infected bullous or infected bullous lung disease, one needs evidence of bullous lung disease on prior imaging. So you can see in this image on the left is a patient with pre-existing bullous lung disease, and then on the right now with infected bully showing air fluid levels. In terms of cystic bronchiectasis is one of the less common morphological forms of bronchiectasis. The other two are cylindrical and varicose. It's characterized by saccular dilatation of the bronchi that extend to the pleural surfaces. When they aggregate, sometimes they have this bunch of grapes-like appearance. And characteristically, there's a lack of bronchial tapering on imaging with an increased broncho-arterial ratio with sometimes a signet ring appearance being described. So in terms of cavitary lung lesions, there's quite a wide differential list for cavitary lesions, and these include both infectious and non-infectious causes, which I've tabulated on the next slide. Diagnosis is usually made with appropriate imaging and laboratory investigations that usually accompanies patient symptomatology and risk factors, which would include environmental and occupational exposures. Chest imaging findings can guide clinicians to a particular diagnosis. And an example would be if you see, for example, multiple peripheral nodules with varying stages of cavitation, then you might want to think of septic emboli or Langerhans cells histiocytosis or possible infarction. So CT is more sensitive than a chest X-ray. And in terms of pathophysiology, A cavity is usually a result of a number of pathological processes, and these may include suppurative necrosis, like you would see in a pyogenic lung abscess, or caseous necrosis, like you'd see in TB, ischemic necrosis that you would see in pulmonary infarction, or cystic dilatation of lung structures, like that you would see with ball valve obstruction and pneumocystis pneumonia, or even displacement of the lung tissue by some cystic structures, like we would see in echinococcal infection. So in addition, malignant processes can cavitate, and this is sometimes because of treatment-related necrosis or internal cyst formation, or most commonly due to internal desquamation of the tumor cells with subsequent liquefaction. Okay, so then this is just a brief table, again, non-exhaustive, but sorry, in terms of non-infectious etiology, so cavitating pulmonary metastatic disease would include squamous cell carcinoma, adenocarcinoma, even sarcomas. Cavitating malignancies would include primary bronchogenic carcinomas. And other non-infectious causes would be non-infective granulomatous disease, like granulomatosis with polyangiitis, or rheumatoid arthritis with lung involvement, particularly with rheumatoid nodules. Vascular non-infectious causes would be, again, pulmonary infarction, which we've mentioned, and pneumatoceles or pneumatoceal development in trauma. In terms of infectious etiology, again, many infectious diseases, but common and important in our setting would be pulmonary tuberculosis, pulmonary bacterial abscess with cavitating pneumonia, septic pulmonary emboli, and other rarer infections like coccidioidomycosis, actinomycosis, which Leo discussed in last week's talk, nocardial infection, melioidosis, and pulmonary cryptococcosis. So we'll discuss causes of acute cavitary disease now, and the first one we'll discuss is lung abscesses. So a lung abscess is defined as a circumscribed area of pus or necrotic debris in lung parenchyma, which leads to cavity formation. And then after formation of bronchopulmonary fistula, an air fluid level inside the cavity is seen. So lung abscesses can be characterized as acute, so less than 6 weeks, or chronic, more than 6 weeks in duration. And it may be primary as a result of aspiration of oropharyngeal secretions, such that you would see, maybe with dental or periodontal infections, paranasal sinusitis, and also in patients with impaired consciousness that may have issues with swallowing. Microaspirations, perhaps also with chronic gastroesophageal reflux disease, and patients with frequent vomiting. Secondary lung abscesses, so secondary lung abscesses can occur in bronchial obstructions. So obstructions by, for example, a tumor or foreign body or enlarged conglomerate of lymph nodes, or with patients with coexisting lung diseases. And those would be patients with bronchiectasis, bullous emphysema, cystic fibrosis, lung contusions, etc. And then also from spreading from extrapulmonary sites. This is hematogenous spread. Often we see with patients with infective endocarditis, or by direct spreading in the case of bronchoesophageal fistula, for example, or subphrenic abscess. Microbial cultures performed from lung abscesses usually demonstrate multiple pathogens, and these can include microaerophilic streptococci, the viridans group, which were considered most common. So streptococcal species and Klebsiella pneumonia are now more frequently seen as causes of cavitary disease, and less frequently isolated organisms include, Pseudomonas, Haemophilus influenzae, Staph aureus, Acinetobacter species, E. coli, and Legionella. In terms of patient presentations, patients with lung abscesses often have high fevers. They may have night sweats, cough with foul-smelling sputum. They may or may not have hemoptysis. They may present with fatigue and weight loss. And these symptoms can go on for many weeks, longer than what is typically seen for a community-acquired pneumonia. Laboratory test abnormalities would include a leukocytosis with a left shift, perhaps elevated infection biomarkers. But radiographically, lung abscess appears as a cavity with quite thick walls and irregular luminal margins. There's an outer border which typically demonstrates this air fluid level. Lung abscesses are usually unilateral, and solitary, and they predominantly occur in the posterior segments of the upper lobes or the superior segments of the lower lobes. And this distribution is particularly suggestive of aspiration. Lung abscesses can be associated with pleural effusion or an empyema. So this is an axial CT image showing this irregular, thick-walled cavity here with this dependent air fluid level with some peripheral ground glass opacification surrounding it. And then the next one we're discussing is necrotizing pneumonia. So although in American literature the term is used synonymously with cavitary pneumonia, necrotizing pneumonia refers to the development of necrosis and liquefaction together with cavitation in the lung. And this is as a consequence of severe community-acquired pneumonia. So necrotizing pneumonia was first described in adults in about the early 1940s, and then described in children some 50 years later, and now it's becoming increasingly frequent in the pediatric population. Common causes would include Staph aureus, strep pneumoniae, Klebsiella pneumoniae, Haemophilus influenzae, and Pseudomonas aeruginosa. Of special interest is this community-acquired methicillin-resistant Staphylococcus aureus containing the gene for Panton-Valentine leukocidin, which is a toxin known to cause necrotizing pneumonia with quite a rapid development of respiratory failure and shock. So necrotizing pneumonia tends to occur in regions of the lung that are less gravity dependent, not like we saw previously with lung abscesses. And surgical intervention has been recommended early on if lung necrosis and gangrene have started to set in. And this is primarily due to poor antibiotic penetration to the affected area because it's usually compromised by a reduced or absent blood flow. In terms of patient presentation, patients will usually appear quite severely ill with cough, fever, hypoxemia, tachycardia, tachypnea, and they can rapidly progress to respiratory failure and septic shock. One may find raised inflammatory biomarkers, and you may be able to identify a pathogen on sputum microscopy and culture. Characteristic radiographic findings will include areas of consolidation containing multiple foci of poorly defined low attenuation areas suggestive of necrosis. These areas can subsequently coalesce to form even larger cavities, and if the process continues, it can lead to frank lobar gangrene. And gangrene is more common with gram-negative pathogens like Klebsiella and Pseudomonas. Patients can also develop other complications such as pneumonic effusions, empyemas, and bronchopleural fistulae. So this is again an axial image of necrotizing pneumonia. So you can see A and B. There is a large area of consolidation with surrounding ground glass opacification, some septal thickening. This is in the right lower lobe. So there's some areas of lucency here within the consolidation that are consistent with cavitation. So features on CT scan that point towards gangrene include obscuration of the pulmonary arterial supply to that involved segment or lobe, and there usually is reduced contrast material uptake in that lung parenchyma with central necrosis. So A is a contrasted scan, again showing this dense consolidation, bi-basal or bilateral dense consolidation with cavitation and non-enhancing lung there with pointed by the yellow arrow. And B is showing this necrotic lung mass. It's also an axial contrasted CT scan. There's a central area of non-enhancing lung with the red arrow, and it's surrounded by a rim of enhancement with the yellow arrow. So this is suggesting necrosis or necrosis starting. And there's a nodule here at the bottom that looks quite similar. Okay. Then next we'll talk about septic pulmonary emboli, and these can result from hematogenous seeding from an infected extrapulmonary site. So risk factors for this would include patients that use IV drugs, infected invasive devices such as central venous catheters, pacemakers, and other cardiac prosthesis, such as prosthetic valves, for example. Then I've included septic thrombophlebitis, pelvic thrombophlebitis, and Lemierre syndrome, which is septic thrombophlebitis of the internal jugular vein. And Lemierre's typically begins with oropharyngeal infection and frequently involves inflammation within the wall of the IJ. And it may be associated with an infected thrombus within the lumen, some surrounding soft tissue inflammation, and usually a persistent bacteremia with complicated by septic emboli. And other species responsible for septic pulmonary emboli would include staphylococcal species, Fusobacterium, Klebsiella, again, Streptococcus viridans, and Salmonella. Patients usually present again with fever, dyspnea, chest pain, cough, fatigue. They may or may not have hemoptysis. And they can also progress to respiratory failure and septic shock. Blood cultures are quite helpful in diagnosing the culprit pathogen, but active searching for the source is quite imperative. Echocardiography is paramount in ruling out valvular vegetations as a source, and obviously removing any possible source, such as central venous catheters, is vital. So a characteristic feature on radiography is the finding of nodules that are simultaneously appearing in various stages of cavitation. And this is usually because of repeated seeding to the lungs, most often from endocarditis. So as further evidence of hematologic origin, the nodules may be associated with feeding vessels, which I'll show you on the next slide. So this is again a CT image of septic pulmonary emboli. So A is a coronal image. And we see multiple nodules with different stages of cavitation, but the arrow in A is actually pointing to a feeding vessel there with the cavitation at the top. And then B is the axial image again, showing multiple pulmonary nodules with central cavitation. Okay, then we'll talk about pulmonary nocardiosis. So nocardiosis most commonly occurs by, is caused by Nocardia asteroides, which is found primarily in soil. And the respiratory tract, the skin, the GI tract are the primary portals of infection. Pulmonary nocardiosis manifests as, may manifest as acute, subacute, or chronic infection with a tendency towards episodes of remission and exacerbation. The risk factors for pulmonary nocardiosis include patients with defects in cell-mediated immunity, so those patients are predisposed to infection, and other patients would be those who have undergone some solid organ transplant or stem cell transplant, as well as those patients who receive immunosuppressive therapy for whatever reason, those with advanced HIV, and those with lymphoma, leukemia. In terms of primary cutaneous nocardiosis, on the other hand, it's an infection usually found in an immunocompetent host. So patients usually present with low-grade fevers. They may have weight loss, cough, fatigue, chest pain, and other acute respiratory symptoms or acute respiratory failure. The central nervous system, however, is the most common extrapulmonary site of infection with nocardia. So patients may have brain abscesses, and they can thus have symptoms like CNS symptoms of headache, nausea, vomiting, seizures, or even altered mental status. In terms of diagnostics, the diagnosis can be made from microscopic examination of bronchial washings or bronchial alveolar lavage with a modified acid stain and gram stain, or positive PCR of the respiratory samples, as well as culture-based techniques. In terms of radiologic findings, so radiographically, pulmonary nodules and consolidation are the most common finding, and cavitation can occur. The nodules are usually described in a size range of about 0.5 to about 3 centimeters, and quite a high number, almost 75% of cases, have this crazy paving appearance around the nodules or the cavities. And the crazy paving is actually ground glass attenuation. It's within which a pattern of interlobular septal thickening is usually identified. And I have a slide of the crazy paving I'll show you in a bit. So this is a patient with pulmonary nocardia, and this is an axial CT, and this was a 62-year-old gentleman that was receiving long-term steroid therapy for polymyalgia rheumatica. And this scan demonstrates this area of consolidation here, this dense consolidation with the central cavity in the right upper lobe. And there is some small adjacent ground glass opacification surrounding it as well. So this is a scan of crazy paving, and this is what crazy paving in the real world looks like, and then superimposed in the lung fields. Okay, then briefly about cryptococcal infection. So pulmonary cryptococcus can be caused by Cryptococcus gattii and neoformans, and the respiratory tract is the principal route of entry for infection, and this is via inhalation of the fungal spores. Cryptococcosis predominantly occurs in immunocompromised patients, but can be seen sometimes in immunocompetent hosts, particularly those that are exposed to pigeon droppings. And the spectrum of pulmonary cryptococcosis usually depends on the host's or defenses, or how intact the host defense system is. And patients typically present with fever. They may have a cough or shortness of breath, chest pain, headaches, or non-specific respiratory symptoms. And some patients may even be asymptomatic. So sputum culture, beta-D-glucan, serum latex agglutination, or serum lateral flow assay results may be positive. And in terms of CT findings, so in immunocompetent patients with pulmonary cryptococcosis, you usually see pulmonary nodules, and the nodules are most often multiple in nature. They're usually quite small, so they're smaller than 10 millimeters in diameter, and they're well defined with smooth margins. The nodules usually involve less than 10% of the lung parenchyma and tend to be distributed more peripherally. So sometimes the nodules can be bilateral, and sometimes they can be associated with cavitation. Quite a high number can be associated with cavitation. It's said in the literature up to 40%. Occasionally, unusual presentations with large cavitations may actually be seen. So this is a patient with pulmonary cryptococcosis, and you can see some scattered pulmonary nodules, and then with some cavitation there. So coccidioidomycosis, on the other hand, is caused by the fungus Coccidioides, and this organism is endemic in the soil, commonly described in American literature in the southwestern United States and some parts of Mexico, Central and South America. And acquisition is typically via inhalation of the arthroconidia, which become airborne. It's described usually after some, natural disasters like earthquakes, dust storms, fires, and some human-related events like agriculture, recreational activities, etc. And risk factors for the infection would include patients with AIDS, patients with hematological malignancies, pregnant women, diabetics, patient with cardiopulmonary disease, smoking, and I think the male sex is also said to be a risk factor. In terms of patient presentation, in primary coccidioidal infection, which is acute, the majority of patients are either asymptomatic or will have mild influenza-like symptoms. So others tend to develop symptoms similar to acute bacterial pneumonia. So they'll have a cough or fever and chest pain, and some distinguishing features, however, are this profound fatigue that patients usually present with. They may present with some dermatological manifestations as well, such as erythema nodosum or erythema multiforme. They may have arthralgias, and it's usually a subacute time course. In terms of diagnostics, this would include complement fixation tests, immunodiffusion, and you can examine the urine for fungal antigen. The most common radiographic manifestation of the acute form is focal or multifocal consolidation, but pulmonary nodules are another common feature and are similar to size in those nodules that we saw with Cryptococcus. So usually there's less than 10 millimeters. And cavities can be seen in a small number of patients with acute primary infections, and these tend to resolve spontaneously, but they can persist and become chronic cavities. Another interesting feature with this infection is this phenomenon called phantom infiltrates, in which you may see parenchymal consolidation appearing at one site, it then resolves and then reappears at a new location. And a peripheral located cavity can rupture into the pleural space and can also lead to a pneumothorax. So so A is actually a chest radiograph of a young man, a 22-year-old male that was initially thought to have a spontaneous pneumothorax, but on closer inspection, you can see obviously there's a obliteration here indicating an effusion, and there seems to be a lesion at the top there. And then this is the same patient in B with this CT scan now that's showing a hydropneumothorax in the right lung and the solitary thick-walled cavity in the right apex. And wedge resection of this lesion actually demonstrated granulomatous inflammation, and coccidioides was identified as the in sputum culture and on PCR. Okay, so the next acute cavity we talk about is aspergillus. And aspergillus is commonly found is a commonly found environmental mold that can cause a spectrum of pulmonary disease. And this could include aspergilloma, chronic necrotizing aspergillosis, and invasive pulmonary aspergillosis. And the host is in the host who is immunocompromised. The inhaled aspergillus can invade the vasculature and cause subsequent infarction and tissue necrosis. So invasive pulmonary aspergillosis is seen primarily in patients with prolonged neutropenia, patients with solid organ transplants, or even patients with T-cell deficiencies. And other risk factors would include chronic obstructive pulmonary disease, diabetes mellitus, and liver cirrhosis, or even long-term steroid use. And this is a scanning electron microscopy of aspergillus demonstrating these pretty
and very difficult. It is like especially on newer antifungals, the tisavuconazole, posaconazole, they're too expensive and.
Sorry about that. I'm not sure what happened there. In terms of patient presentation, so patients may present again with symptoms of pneumonia, which would include a productive cough, dyspnea, chest pain. They may or may not have hemoptysis, and usually with fevers are unresponsive to antibiotics, or not the fevers rather, but the patients would usually be unresponsive to antibiotics. In terms of diagnosis, the histopathology and the use of fungal-specific stains play an important role in the diagnosis of infections by Aspergillus species. The identification of fungal elements in histological sections or fresh clinical specimens of bronchoalveolar lavages and biopsies are diagnostic. But culture from a clinical sample is still the gold standard for diagnosis, and obviously has the advantage of yielding the specific etiological agent and would allow for susceptibility testing. Antigen and PCR-based techniques are add-on assays to culture and microscopy. And in terms of radiographic presentation, a halo sign is usually described, and it's a ground glass attenuation surrounding a solid central core. And the ground glass component represents pulmonary hemorrhage that is due to the angioinvasive nature of the aspergillus. So 1 to 2 weeks after the halo sign appears, especially following successful treatment, nodules cavitate in up to 63% of patients. And this can lead to another sign called an air crescent sign. And this is as a result of the tissue necrosis. So another radiographic appearance of invasive pulmonary aspergillosis will include pleural-based wedge-shaped areas of consolidation. And this corresponds to hemorrhagic infarcts. So in this patient, so A and B are not the same patients, but A is demonstrating multiple solid nodules here. You can see them here scattered all over, multiple solid nodules surrounded by this halo of this ground glass of pacification, this like very fuzzy margin. So that's the halo sign. And patient B is a coronal high-resolution CT, and it's demonstrating this crescentric lucency surrounding the nodule. And there's a crescentric lucency, and this is the crescent sign. Okay, so the next one we are talking about is mucormycosis, and this is an infection caused by molds belonging to the order Mucorales. So Rhizopus and Mucor are the two genera most commonly noted to cause infection. And pulmonary mucormycosis is an uncommon fungal infection, and it's mostly seen in immunocompromised patients. The fungus itself grows on decaying food, soil, and animal excrement. And patients usually become infected by inhalation of the spores. And the most common risk factors would include patients with diabetes, hematologic malignancies, or solid organ and even stem cell transplants. Patients with mucor are often severely ill, and they may present with fevers, cough, dyspnea, pleuritic chest pain with or without hemoptysis. At laboratory analysis, the positive beta-D-glucan result is not seen here because mucor and rhizopus don't actually produce this polysaccharide. The diagnosis is usually made by histopathologic testing. Radiographically, the manifestation overlaps invasive pulmonary aspergillosis, which we just saw. But more commonly than invasive pulmonary aspergillosis, a reversed halo sign may be seen. And this is defined as this curvilinear solid density surrounding a core of ground glass attenuation. But as with invasive pulmonary aspergillosis, masses, nodules, the halo sign itself, consolidation, and cavitation can all be seen. So this is again CT images. So A is well, not A, or the image on the left is an axial image in a patient with invasive pulmonary aspergillosis showing a halo sign. And then B is a coronal image of another patient with mucor, again showing the halo sign. So just showing the similarities between the radiographic presentations between the two. Okay, so we're moving on to chronic cavitary disease now. And the first one we'll just talk about is mycobacterial infection. So we know it's the most important, high prevalence in our country, but usually caused by Mycobacterium tuberculosis, and risk factors would include endemicity, exposure, and retroviral disease. Patients would present with the classic, chronic cough with sputum production, weight loss, fevers, night sweats, loss of appetite, hemoptysis, etc. And pulmonary TB can obviously be diagnosed on sputum for AFB, PCR gene expert, or TB culture. In terms of radiological appearance, so fibrocavitatory disease occurs in about half of the patients with reactivation TB, and is seen more often in the apical and the posterior segments of the upper lobes or the superior segments of the lower lobes. Fibrocavitatory disease is defined radiographically as pulmonary infiltrates, which are characterized by nodular densities with some fibrous scarring, may have some volume loss due to the scarring, and of course, cavitation. So this is the patient with TB, and we can see this nice thick-walled cavity with some multiple tree and bud opacities, which appear posteriorly in the apical segment. Okay, then briefly, non-tuberculous mycobacteria. So NTMs are ubiquitous in the environment, but concentrations are highest in water and soil. The most common organism associated with and risk factors for the disease would include profound immunosuppression, such as HIV, patients with transplant, patients with structural lung diseases with architectural distortion, such as that would be seen in chronic obstructive pulmonary disease, patients with silicosis, or even prior TB infection, and patients with CF or cystic fibrosis. Patients with NTM may present with, again, chronic productive cough, hemoptysis, very similar presentation to TB. And patients with NTM may have positive sputum microscopy or culture results. In terms of imaging, so MAC appears quite similar to that of TB with upper lobe fibrocavitatory disease. But the cavities due to MAC may be smaller or thin-walled, and the disease is more, progresses more slowly. And common associated imaging findings would include tree and bud opacifications and may or may not be associated with bronchiectatic change. So this is a series of images, A to G, in a patient with non-tuberculous mycobacterial infections. So we can see first A and B are coronal CT scans, and this was actually a 68-year-old woman with sputum culture positive non-tuberculous mycobacteria, and you can see it's demonstrating these thick-walled cavities. And then in B, we can see this arrow pointing to some bronchiectatic changes. And then coronal CT scan D demonstrates this fibrocavitatory disease in the lung apices bilaterally, and there's some traction of the hyla and the fissures. Okay, in terms of fungal disease causing chronic cavitations, so chronic necrotizing aspergillosis is a cause, and it's usually indolent. It's a destructive process due to aspergillus in the lung, which can be differentiated from invasive pulmonary aspergillosis based on the chronicity. And almost all patients with chronic necrotizing aspergillosis have underlying structural lung disease and may have COPD. They may have inactive or previously treated TB, a prior lung resection. Some patients may have been exposed to radiation therapy previously. Also, patients with cystic fibrosis or lung infarction are at risk. Patients would usually present with fever, cough, sputum production, dyspnea, hemoptysis, anorexia, weight loss, or even malaise. And the most sensitive laboratory test is an Aspergillus IgG antibody, with sputum Aspergillus PCR being more sensitive in culture. Unilateral or bilateral cavitatory lesions can be seen on imaging. It's usually in the upper lobes, and it can be associated with some adjacent pleural thickening. And it may also progress to bronchopleural fistula formation. And approximately 1/2 of these cavities can develop an aspergilloma. So this is an axial CT scan demonstrating the solid mass in the dependent positions within the biapical cavities, and this is consistent with fungal balls. So the images on the right, this is image C, is again demonstrating the fungal organisms highlighted here by the Komori methamine silver stain. So another cause of chronic cavitation is histoplasmosis infection, and this is caused by the dimorphic fungus Histoplasma capsulatum. The fungus typically lives in soil that contains large amounts of bat and bird droppings. And patients, again, with structural lung diseases, like those with COPD, again, are at risk, as well as immunocompromised hosts. Again, non-specific symptoms here, productive cough, malaise, fevers. They may have night sweats, less commonly chest pain due to mediastinal lymph node enlargement. But they may also present again with erythema nodosum, erythema multiforme, arthralgias, arthritis, etc. The positive complement fixation titer and sputum fungal stain and culture results, and a positive histoplasma antigen in the urine, blood, or bronchoalveolar lavage all support the diagnosis. Radiographically, cavities here typically are found in the upper lobes and associated with fibrosis, or associated fibrosis can be seen in a high proportion of patients. The findings of numerous punctate calcifications can also be seen in the spleen, the liver, the mesenteric lymph nodes, and this is particularly suggestive. So this, again, this is an axial high-resolution CT scan A demonstrating a thick-walled cavity with eccentric calcification here in the right upper lobe. And then B is this coronal scan, again demonstrating this the same lesion. And then picture C is the mediastinal window. And then I think what's important here is you can see these multiple punctate calcifications in the spleen. Okay, so the next infection is blastomycosis. And this is a pulmonary disease caused by inhaling spores of the dimorphic fungus Blastomyces dermatitidis. And occasionally the fungi spread hematogenously, causing extrapulmonary disease. And Blastomyces grows as a mold at ambient temperature in the soil, and it's usually soil that's enriched with animal excreta and in moist, decaying, acidic organic material, often found near rivers or riverbeds. In the lungs, the inhaled spores convert into these large invasive yeasts, which form this characteristic broad-based buds. So it's more commonly seen in a host who is immunocompetent. These patients are often in asymptomatic, but in those who do develop symptoms, the illness begins about 30 to 45 days after exposure. And the patients would usually present here with cough, fevers, night sweats, weight loss, and malaise. The skin is the most common extrapulmonary site here of infection. It often begins with this papulopustular lesion that progresses to this ulcerative verrucous or crusted lesion. The bone is also a common extrapulmonary site, or the second most common extrapulmonary site. And most patients here would present with osteomyelitis. Patients may have a positive sputum smear or culture or urine serum or bronchoalveolar lavage Blastomyces antigen. In terms of radiographic representation, so cavitation can occur less frequently in blastomycosis than in histoplasmosis and TB, but cavities can have thick or thin walls here. They can be single or multiple, and they're more commonly located in the upper lobes, and they quite commonly result in post-treatment scarring. So again, series of images. A is showing these two hyperkeratotic verrucous papules, and this is a patient with cutaneous blastomycosis. And then photograph B shows this discrete, again, hyperkeratotic ovoid pink plaque. This is the yellow arrow pointing to it in a patient with cutaneous blastomycosis. This is the same patient. And C is this axial image showing multiple cavitatory lesions bilaterally. And there's some small airspace opacities throughout the lung, most prominent in the upper lobes. In terms of parasitic infection, so the trematodes of the Paragonymous genus cause Paragonymyces, a parasitic disease that strikes carnivores. It causes a subacute chronic inflammatory disease of the lung. And of the 10 or more Paragonymous species that are human pathogens, only about 8 cause significant infections. The most common is the oriental lung fluke, Paragonymous westermanni, and it's associated with the ingestion of raw freshwater crab or crayfish. And about 20% of patients with this disease are usually asymptomatic, but others may present with abdominal pain, diarrhea, urticaria that can occur in the acute phase of disease, and that corresponds to the period of invasion and migration of these immature flukes. The initial symptoms are followed by a few days later by cough, fever, dyspnea, chest pain, malaise, and sweats. And the acute phase usually persists for several weeks. During the chronic phase, manifestations may be pulmonary or extrapulmonary, and chronic pulmonary symptoms usually include a dry cough. It may be followed by, later on, by productive cough with this tenacious, rusty, golden-colored sputum that's often described. Pulmonary symptoms usually begin approximately 6 months after the ingestion and can often be mistaken for pulmonary tuberculosis. A definitive diagnosis of Paragonymyces requires detection of the eggs in the sputum, feces, pleural fluid, or even the CSF or pus. However, eggs may not be present in feces and sputum for about 2 to 3 months. And worms or eggs may be found in biopsies of pulmonary cerebral, subcutaneous, or intra-abdominal nodules, or even cystic lesions. Radiologically, the abnormalities may include ring shadows, which represent cavitating lesions. There may be fibrosis, nodular involvement, and linear may have some loculated pleural effusions, and which may or may not be associated with pleural thickening. So echinococcus is the other one, or hydatid disease, which is caused by the larvae of echinococcus. This is in the metacestoid stage of the tapeworm. And in cystic echinococcus, humans are an accidental host and are usually infected by handling an infected dog. The liver and the lungs are most frequently involved, and pulmonary disease appears to be more common in younger individuals. Patients are often asymptomatic for many years. However, if signs or symptoms develop, chest pain, cough, hemoptysis, and pneumothoraces can be seen. Other symptoms patient may present with is wheezing, fever, urticaria, and possibly even anaphylaxis if any of the antigenic material is released from the cyst. In terms of radiology, liver cysts are the most common finding. However, in like 20% to 30% of cases, lung cysts can develop. If air enters the ruptured cysts, it can appear as a crescent-shaped lucency, or it can have this cavitary appearance. There also may be evidence of a collapsed laminated membrane that floats inside the cavity, and it produces what they often call a water lily sign, although I find it very hard to appreciate. But I'll show you this water lily sign on the next slide. So this is an axial high-resolution CT in a 37-year-old admitted for treatment of echinococcus pneumonia. And you can see there's a thick-walled cavity, yes, with this collapsed laminated membrane here. And this is apparently called the water lily sign. Okay, we are nearly done. In terms of viral infections, HPV can cause, or human papillomavirus can cause tracheobronchial papillomatosis, and chronic infection with HPV can result in multiple papillomas within either the nasopharynx, the larynx, the tracheobronchial tree. Respiratory papillomas may undergo some malignant transformation in a number of patients, about 3 to 5% of patients, I think it's described, and it may transform to a squamous cell carcinoma. Symptoms, again, non-specific respiratory symptoms, and the diagnosis is usually made by means of a transbronchial biopsy. Radiographic features would include mucus plugging with what's described as a finger-in-glove appearance. Patients may also have atelectasis, and they may also have other solid cavitary nodules. So pulmonary nodules can range here from about 0.5 centimeter to about 5 centimeters in sizes, so it can be quite large nodules. So this is an axial CT scan demonstrating this thick-walled cavity with an irregular nodular margin, and this is due to tracheobronchial papillomatosis. Okay, so now just coming to a quick algorithmic approach to narrow our differentials when we are faced with the patient. So we basically have a patient, we suspect a cavitary lesion, and we see these focal hyperlucencies, and we suspect pulmonary cavitary disease. So the first step would be to confirm that this is a cavitary lesion and it's not a mimic. And the mimics we described earlier on as being either cyst or emphysema, infected bullae, or cystic bullous lung disease, right? So that would be to exclude the mimics, and you can do this, of course, on imaging. The other important thing to do would be to review older imaging, and you see that would be especially true with infected bullous lung disease. So it would be important to have old imaging if you do have access to it. Then the next step would be to decide on whether this is an acute presentation, so if it's less than 12 weeks, or if it's chronic. And then this helps us narrow down our differentials. So if we're suspecting autoimmunity, we need to look for other features that might be in keeping with rheumatoid arthritis, for example, or patients with granulomatosis and polyangiitis. So a good clinical history with appropriate investigations would help us come to that diagnosis. If we're suspecting malignancy, of course, we'd have to look at patients' risk factors, what the presenting complaints are, smoking history, family history, all those associations. And then we can think of a primary lung cancer or metastatic lung disease that might be causing it. In terms of chronic infections more than 12 weeks, we've spoken about TB, non-tuberculous mycobacterial infections, some of the fungal, parasitic, and the viral causes. That we could use patient symptomatology, again, the duration, because we're looking at more than 12 weeks, together with risk factors. And then if it's acute, if it's less than 12 weeks, the acute infections we spoke about were lung abscesses, necrotizing pneumonia, septic emboli, fungal infection, and nocardial infection. And again, a good clinical history is imperative, appropriate investigations, and looking at the patient's risk factors. And by combining all of these together, we should be able to come up with a reasonable differential. Okay, so these are my references. Thank you.
Cool. Thanks, Tyral. So yeah, important topic, as you say, the association with organisms is pretty interesting in terms of pneumonias. That we think of Staph aureus and Klebsiella and anaerobes and things like that as being cavitatory causes. Interestingly, strep pneumo keeps topping the list there. So it's probably just again due to the difference in prevalence, right? So that although it's unlikely for any episode of strep pneumo, because strep pneumo is so common, it makes it the most likely cause overall, which is interesting, a little bit counter to some of the sort of traditional teaching on this. The common questions in the chat, and a very, very good question, is about what to do about these abscesses that you see on a chest X-ray in a patient known with TB. So the question is, in the context of confirmed pulmonary TB in a relatively well patient, should you treat what appears to be an abscess on chest X-ray with, say, 6 weeks of augmentin in addition to the TB treatment, or is it more likely to be a TB abscess?
So this is in patients who we've already got a diagnosis of TB.
Yeah.
So again, I would start TB treatment, and I would evaluate the patient response and perhaps look at repeating the imaging and obviously looking at how the patient is responding to the TB treatment, and then maybe consider other causes.
Yeah, as you rightly said, TB causes abscesses, so it can be very difficult. And then, of course, the post-TB bronchiectasis may be complicated by bacterial abscess, so it is a bit tricky. But I think in general, I agree with you. I err definitely on the side of just assuming it's TB. But of course, the pattern helps a lot. If you've got old X-rays of TB of the same patient, and in suddenly month 5 you get a new abscess, then that's unlikely to be the TB, assuming that the patient's taking the treatment. Whereas if you're finding it an abscess more or less contemporaneously with the gene expert positivity, then it's very likely to be TB. So I think the pattern and the timing obviously makes quite a lot of difference. Cool. Are there any other questions? Just type them in the chat. I'm just looking through the chat as well. Satina Law makes the point that several isolates previously for nocardia identified as nocardia asteroides were actually instead nocardia fossinica or nova. There's a reference for that there too. Interesting. Sorry, I'm just posting through. Some of them are different stages and different parts of things. And your approach to treatment in terms of, let's say it's an abscess, because that's a sad outcome of much of the stuff. So let's say it's a pulmonary abscess, not a necrotizing pneumonia, but just a pure abscess. What would you advise in terms of treatment for that, Tyral?
So definitely physiotherapy would be important. So postural drainage with physiotherapy. Again, broad spectrum antibiotics, and we know again, strep pneumonia, like we said, is commonly tops this list. And then just to be wary of any other complications that may be associated. For example, if there's an empyema that's developing, then obviously this patient needs adequate source control, possibly an IC drain insertion, and then also cardiothoracics to be involved if we're having difficulty getting source control.
Yeah, exactly. So I think for pure abscess, strep pneumo is unlikely. It's quite low down the list, but as opposed to necrotizing pneumonia, which is a bit different. But point's well taken. You've got lots of anaerobes there, Staph aureus, that sort of combination. So usually something like augmentin or clindamycin, I think, is the US recommendation, is another option. Although I must be honest, I'd much rather take augmentin than clindamycin for several weeks. And as you say, then working up some of the rarer causes, which is important, like TB and nocardia and the rest of it.